On diagnosticoscopy, we see the PCL is lax and there is pseudo laxity in the ACL. Now we go ahead and create the posterior portal slightly higher up above the capsular fold so as to access the PCL footprint easily. Alternating between the underwater pottery and shaver, we gradually clear the PCL stump of the tibial footprint, taking utmost care not to go behind the septum as the major neurovascular bundle is just behind the septum. With a special PCL curate, we clear all the soft tissues between the two mammillary bodies and recognize the PCL footprint. While determining the exit point for the bead pin on the tibial footprint, one should be careful. The guide should not be put too distally below the champagne drop off so as to avoid the killer turn on the graft. Also, the guide should be nearer the lateral mammillary process so the graft is slightly lateral on the footprint, which is its anatomical position. On exit, your bead pin should be safely captured within the guide and should not propagate further so as to avoid injury to the neurovascular structures. After finding the position of the pin satisfactory, we proceed ahead to rim the tibial tunnel by keeping a special PCL protector cum curate in situ. We start rimming the tunnel, and while coming out of the cortex, the rimmer is turned manually to avoid posterior blowout and hitting the neurovascular structures. The soft tissue from the edges of the tibial tunnel is shaved off so as to avoid obstruction while passing the graft. For the femoral tunnel, I use the chosen rimmer itself as a guide and pass the bead pin first through it, keeping its anterior margin flush to the femoral cortex so as to keep the tunnel as anatomical as possible. Now, weaving from the posterior portal, we pass a bead pin loaded with an ethylon and we deliver it out of the anterolateral portal. We have drilled the femoral tunnel through and through. It is easy to pass a suture retriever through the tunnel and deliver the ethylon which is passed from the tibial tunnel now through the femoral tunnel so as to railroad the graft. On the femoral side, we are using an ABS button and a no button loop to fix the graft. On the tibial side, we use a screw to fix the graft. Now, since we have an adjustable loop on the femoral side, after railroading, we can retension the graft as much as we want so as to avoid post-op laxity. Fixing the graft with a screw on the tibial side, we can again cycle the knee throughout the range and check for any laxity in the ligament so that we can retension the graft from above as we have used an adjustable loop on the femoral side. Here we see the pseudo laxity of ACL is now obliterated and the PCL itself is now in adequate tension. Viewing from the posterior portal, we can see the graft going into a tibial tunnel just above the champagne drop off so as to avoid the killer turn. Thank you for watching the video.